Good evening, everyone, and welcome to this event. My name is Alessandro Tulli. I have the honor to be the general manager of this clinic, and I don't want to bore you with any speech. I just want to hand over to the main person and most important person of this night, Chris. Dr. Chris.
Why I will pay you for you don't want to talk. So, thank you all for coming. The month of November is always focused in the past 15 years on male health. And we decided for our first year in these premises to touch upon a topic that is very, very interesting. Many males, some females, they think it's still a taboo. But in our daily practice, thank God it's not a taboo. People come here, they disclose all the information to us, and we start facing with them together the challenge to help them become better. I am very happy today to have with us a renowned medical doctor. He is one of the top, literally, in the world. I will not say which position, but the top 3 is good enough. Okay, he's coming from Greece. It's by chance that I'm Greek as well. We know each other for quite some time. He has some of my personal patients in Greece. He's taking good care of them, and he was kind enough to join us today. He will talk to you about testosterone and longevity, and then I have some questions from the people who were shy to show up here. And hopefully we'll have some discussion. Feel free to ask any question. There are no stupid questions in general, but also for male health. And yeah, thank you for coming on Friday night. I hope you'll enjoy the Friday night afterwards. I mean, we have a nice Weihnachtsdorf next to us, but please don't drink so much. So, George, Dr. George Touliatos is a biopsychologist. He used to be an athlete as well. He still trains a lot. He doesn't like the people who misuse testosterone for the wrong reasons. And he has helped many, many people until now, not only in Greece, but from India and Pakistan to the States, Switzerland, and so on and so forth. So I hand over to him, and you can bombard him after the presentation. Thank you.
Good evening. My presentation will be about the testosterone and longevity. So, testosterone replacement therapy in men. So, as we age, our hormonal environment corresponds to the process of aging, and the steroid hormones decline, meaning the testosterone, the DHA, and the DHT, the 3 main androgens. After the age of 40, the average reduction of testosterone is around 10% per decade, so 1% annually. This decline is noticed in free testosterone because of the elevation of SHBG, which is the protein carrier. And actually, free testosterone is reversely related to this HBG. So the higher the SHBG, the lower the free testosterone. And what is important about the free testosterone is the one at work, is the bioavailable testosterone, because the total testosterone is inactive. So it doesn't matter how much is the total testosterone unless you know about the free testosterone. And the relation of free testosterone and HBG is reversely related. The majority of the testosterone, 98%, is bound to the HBG, but the only 2% is not bound, which is the one that flows in the cervix. So after the age of 40, we hit the so-called andropause. So this could be even in the 30s or the 50s, depending how the person lives. So the main symptoms is low in sex drive, the libido, the urge to have sex, to have flirt. As Professor Mortitaler of urology in the Harvard University says, testosterone is a cerebral hormone, meaning it's something that comes from the limbic system, and it gives you the instinct to have sex. Then is the drop in the erectile dysfunction, meaning the blood flow to the penis, because we know that testosterone improves the nitric oxide synthesis. Therefore, we have vasodilation in the cavernous bodies. Then we have a reduction in muscle mass. This is a main symptom. known as sarcopenia, which is the muscle wasting. And the less muscle you have, the more visceral fat you develop, and the more visceral fat you develop, the more the insulin resistance. And then the visceral fat releases estrogens, and mainly estrone E1, that is also linked to the inflammatory cytokines. But what's important about the muscle tissues, the less muscle we have, the weaker the bones, because as the muscles get stronger, they attach to the bones, and the bones as a result become denser. So osteopenia and osteoporosis, which is very important in the elderly, is a result also of poor muscle tissue as a result of the drop in the testosterone. Also we have, because testosterone is a cerebral hormone, it has results in the how you feel, which is the low self-esteem and the self-confidence and the depression. We know that testosterone is antidepressive. So the reduction of testosterone to DHT is a main antidepressive hormone, and we understand this by people who get castrated under prostate cancer. So when you remove the testicles or you shut off the testosterone from the brain by giving analogs of LH, then you reduce the testosterone, and then this person develops depression, has no willpower at all. Moreover, the testosterone is improved, two main neurotransmitters, the serotonin, which is the joy hormone, and the dopamine that is dealing with the feeling of reward. Also, testosterone is a cerebral hormone that improves cognitive function. So many people complain about this foggy mind because of the low dopamine and the poor cognitive function. And as I said before, the low bone mineral density, the osteopenia, that leads to osteoporosis and bone fractures. So in other words, low testosterone is associated with higher mortality and increased fatality, okay, and premature death. Cardiovascular disease, diabetes type 2, is the result of the metabolic syndrome. Alzheimer's disease also, depression, bone fractures, poor muscle coordination. In few words, aging. As I said before, testosterone is antidepressive by two main mechanisms. It's a growth hormone to DHT. DHT is antidepressive. Also, proviron is a synthetic form of DHT. Proviron improves the mood, and it improves serotonin and dopamine. What is tricky about psychiatrists is that many patients complain about being sad, and they just give them SSRIs. However, the psychiatrists do not find what lies beneath. If there is low testosterone, and actually if there is low and free testosterone, then they develop depression. But no psychiatrist is interested to deal with this, simply because if you treat depression with testosterone, they're going to miss the prescription of these SSRIs. The same happens with the urologist. Somebody goes with a pure erectile dysfunction, but the urologist is not interested in searching beneath if there is a hypogonadism. And as a matter of fact, testosterone not only improves the libido, the sex drive, but also improves the blood flow because it improves the nitric oxide, hence it improves two-in-one, both the will to have sex and also the good erection. And as a result of this, testosterone can pull out the prescription of the phosphodiesterase inhibitors, meaning the Cialis or the Viagra. So testosterone can kill the prescriptions of antidepressant drugs and erectile dysfunction drugs, and this is not cool about the big pharma. Now, what causes low testosterone? It could be testicular trauma, that means testicular failure, primary hypogonadism. It could be also chromosomal abnormalities like the Klinefelter syndrome. We have the 47XXY, meaning those boys are not well developed in puberty and they need to use testosterone for life, and also they are infertile. Now, cortisolemia due to chronic stress and poor sleep quality could lead also to secondary hypogonadism. And chronic diseases, meaning obesity, hypothyroidism, metabolic syndrome also are suppressive. Now, it is interesting to understand that low testosterone leads to obesity because testosterone is capable of oxidizing the fat, but also being fat shuts off the brain for testosterone production. So it's one also, but it's also the other. So they give you this, endocrinologists tell you just this false dogma, just drop on weight. The point is you cannot lose weight if your testosterone is low because your batteries are empty. You can only increase your testosterone as long as your levels are above mid-range. So if somebody has testosterone below 300, he has no energy and no willpower to lose weight and to exercise in order to increase his own levels. And this is happening because doctors do not know what fitness is all about. As a bodybuilder, I used to know that only with testosterone we're able to do these fantastic things in the gym. Now, if you're dieting, you're under caloric deficit, and if you're fat, you need to do something really strong. It's like walking uphill against the wind. So only with high levels of testosterone you're able to lose fat, and this is something that happens only in eukaryotic people. Other medications that lowers testosterone are narcotics, opioids, painkillers, okay? Barbiturates, diazepam, for instance, in order to sleep. The SSRIs that increase also prolactin. Now, some diuretics like spironolactone and aldosterone inhibitors, glucocorticoids, meaning cortisone, and of course, weed, marijuana, that increase prolactin. Now, the use of testosterone is the epitome of anti-aging and the basis of the TRT. What are the benefits of testosterone? So it's increasing muscle mass, strength, and endurance. Increasing muscle mass and strength is because muscle gets stronger, but endurance is the result of EPO production. And as EPO increases, then hemoglobin and myoglobin increase, and as a result, the oxygen carrier into the cells, and mitochondria as well. Now, increasing muscle mass means that you have more higher BMI, and higher BMI means higher metabolic rate. And the higher the metabolic rate, the lower the subcutaneous fat. The smaller the midsection, and the improved insulin sensitivity and low the A1C. As a result of this, we have a reduction in metabolic syndrome. Now, realize that if this happens, how the heck endocrinologists are able to give semaglutide to somebody who's 300 pounds with low testosterone? So you need to combine both GLP-1s along with testosterone in order to have the perfect muscle loss. Otherwise, just with semaglutide, you're going to waste your muscle by having low testosterone dieting as well. So you need a combination of high energy with testosterone that preserves also muscle tissue that will restore the basic metabolic rate, along with the caloric reduction that the GLP-1s bring out of satiety. Now, other benefits of testosterone is how they treat osteoporosis, the calcium reuptake in renal tubules. So you're able to restore the calcium, and under the presence of vitamin D3, then you have a better bone mineral density. And we understand this also because muscle gets stronger, and as muscle gets stronger, the bones get as well stronger. All right? So the nitric oxide, as I said before, it improves the vascular permeability and the blood flow in the penis, okay? We athletes know that when we take testosterone, we get more vein into our arms, and this is the result not only because of the fat reduction, but also because of the nitric oxide production. Now, the increase in insulin sensitivity, as I said before, is because of the reduction in subcutaneous fat and visceral fat, as the testosterone oxidizes the fat, but also as testosterone increases the muscle mass, that increases the basal metabolic rate. Now, in the mental sphere, we have increasing self-confidence, self-esteem, mood, cognitive function, all right? And of course, it reverses depression. Dopamine and serotonin improve. And as I said, DHT is reduced, so testosterone is the prohormone to DHT, and as DHT is released, then the self-esteem, but also the sex drive improve. As a matter of fact, DHT is 5 times more androgenic than testosterone. And testosterone is the main hormone that separates men from boys. Here are the old tissues where testosterone affects. So the skin, you have the hair growth, but the sebum also production. Sebum is very important because it makes skin more elastic, but it may also capture some bacteria if there's overproduction, and actually sebum is DHT related. Now in the mood, it improves the libido, as Margidal said, it's a cerebral hormone, okay, and the mood, of course. So it's antidepressant. In the muscle, we have stronger muscles, all right, and strength. In the kidneys, we have the EPO that improves stamina and endurance and fight fatigue. In the bone marrow, we have the stimulation of the red bone marrow, the stem cells, the premature cells, okay? In the bone, of course, testosterone, as a matter of fact, accelerates the growth of the epiphyseal plates. That's why we shouldn't administer testosterone to teenagers, only to adults. In the liver, it's produced the CTBG, which is a liver hormone, okay? So if CTBG is increased, it's because perhaps of inflammation in the liver, and the mature during puberty in the secondary characteristics of the sexual organ in the pubis, okay, and the scrotum with the hair growth, and the growth of the sperm as well. Now, what is the blood panel in order to realize that we have primary, secondary hypogonadism? We have the LH and the FSH that are the gonadotropins, okay? We have the total testosterone, the free testosterone, of course, the estradiol, which is one of the metabolites of testosterone, the prolactin, which is an inhibitory hormone to the testosterone, and the protein carrier, which is the sexual hormone binding globulin. Now, we clarify between primary and secondary. The primary means practically that we have a testicular failure. Usually the LH and the FSH are normal or super high, while the secondary actually means that the brain doesn't give the stimulus to the testicles, so we have very low LH in both FSH. There's also the late onset that bodybuilders face out of the steroid abuse, and initially you develop a primary, but then a secondary. And actually this different class of hypogonadism in anabolic steroid user, including myself, the anabolic steroid-induced hypogonadism, because as you give androgen, then you shut off your own production, and eventually you become hypogonadic. This is also how race horses are becoming sterilized. Now, the increase in estrogens. There was a big misconception about, and a paranoia actually, about the estrogens. If testosterone is a very important hormone, it's because it splits in two metabolites, the estradiol and the DHT. Now, age is related also with estrogens because we lose muscle, we develop visceral fat. Obesity also means increased estrogen because we have the aromatase enzyme in the subcutaneous tissue. Now, alcohol also aromatizes in the liver, which is a toxic compound, we know, and as a matter of fact, alcoholics develop the characteristic giant muscle. Now, zinc deficiency could lead to increased aromatization because zinc has antioxidant properties. DHA can increase another form of estrogen, the estrone, which is actually linked to the prostate cancer or breast cancer, the E1, which actually is demonized and is not the main representative like E2, which is the estradiol, all right? And the phytoestrogen is soy. Soy actually is estrogen. Now, the significance of estrogen during TRT, we shouldn't block estrogen by the aromatase inhibitors unless we have symptoms, because estrogens are very crucial for, they are cardioprotective. They increase the HDL, they improve the endothelium. And we understand this when we give aromatase inhibitors without hesitation, and the HDL drops, and actually there's disruption in the inner lining of the arteries, which is the endothelium. Now, estrogens are also neuroprotective to the brain. We know this from bodybuilders that get very moody, grumpy when they use aromatase inhibitors in order to get this super dry look. Estrogen is also very optimal for sex drive for the same reason when we abuse AIs, we kill the sex drive. So men and women need as much of the opposite hormone in order to have an optimal sex drive. We men need a little bit of estrogens as women need a little bit of androgens. And of course, estrogen support bone health, and we know this from menopausal women that after menopause they develop poor bone mineral density, and estrogens are very vital for the bone health. Androgens also as well. So AI should be taken very cautiously under symptoms, and as a matter of fact, I believe the SERMs, tamoxifen is more important, and it's healthier approach because you don't kill the production of estrogens, but you occupy the receptor so that the flow of the estrogens are still remain, but they not can sit on the receptor. So in order to treat symptoms, you can use the tamoxifen. Now, what are the delivery systems? How you administer testosterone? The commonest thing is the parentetic, meaning the injections. So intramuscular or subcutaneous, which is actually, I would say, something less important. The deep intramuscular injection means it goes straight to the bloodstream. Now, the only benefit of the subcutaneous is to avoid the deep scar tissue. As a matter of fact, adipose tissue has a poor blood supply, therefore the compound, the testosterone will not go straight to the bloodstream, just like the intramuscular that has very high blood supply. And another thing is that subcutaneous develops those lumps. So if you inject oil, which is testosterone, into the fat, you develop large lumps of oil, especially if your body fat is low. The only way, if you want to use subcutaneous, is do marker dosing of small amount of testosterone. Let's say testosterone propionate 10 milligrams. You can do this every other day or even on a daily basis. But frankly, you cannot put a decent amount, you cannot inject a decent amount of testosterone through the insulin syringe subcutaneously. So the frequency of the shots intramuscular varies, okay, according to the half-life of the testosterone, and this reflects to the ester. So we have the CPNA, which is around a week, 8 days. The NFA, that is roughly 5 to 7 days. The propionate, which is 48 days every other day. And then we have the anticonate, which is the inhibitor, that's around 12 weeks. What is the advantage of doing more frequent compounds, the marker dosing? As we do marker dosing, we avoid the spiking. As we do less frequent injections, we prefer the spiking. So let's say we inject every Monday. We inject 200 milligrams on Monday. On Tuesday and on Wednesday, we're going to have a tremendous spike on free testosterone that will also produce more estrogens. The flip side of the coin is that if you use daily marker dosing, and the ideal example is the cream. If you do use the cream, you just use a tiny drop of testosterone on a daily basis, and then you avoid the spiking. That means more steady levels and actually less E2, okay, and less and higher SHBG. The higher the amount of testosterone that goes, the higher the crash of the SHBG and the more liberation of the free testosterone that will aromatize. So doing less frequent and higher amounts of testosterone will give you a lower SHBG, and a frequent marker dose will give you a higher SHBG. All right, so this depends actually how the person wants to work. I've tried all the protocols, all right, and after 10 years of pinning myself, I'm tired of doing frequent injections, so I prefer every Monday to do my dose. I don't think there's a substantial difference between if you do it every day, every week, twice a week, 3 times a week, okay? I believe it's only the mind. What matters is that you need to take your blood levels just before taking your dose. What matters is not the spike, and what matters is the trough levels. That practically means that before taking your dose, you need to be at least at 50% and above, okay? Mistakenly, many doctors check out the peak. That doesn't matter at all. We know that the peak is going to be high. The point is, just before taking your dose, you need to have a good, decent level. Now, the Concerta, as I said, it has a steady levels, okay? Now, supposedly, because the skin possesses the 5-aerodutase enzyme, means that you're going to convert more to DHT, and DHT is related also to sex drive and self-esteem, okay? Another thing is the bioidentical liposomal cream that is very friendly to the system, unlike the synthetic alcohol-based, the FDA gels, okay? And of course it's very practical because you carry it in your pocket and you can travel. Otherwise, if you do the injections, you need to carry yourself cotton, alcohol, needles, and some people are not familiar to that. Here on the left, we have the Greek N-alphate, testosterone-alphate, okay? Then on the right we have the American cypionate, and here we have two kinds of transdermal. On the left we have 2% gel, alcohol-based, and on the right we have bioidentical liposomal 20% cream. Now, what is the use of HCG? What's the cause of the use of HCG? What does it do? So, many people get sterilized because the doctors do not know how to maintain the fertility. And wrongly, they do not ask the patient, do you want to have family in the future? And they miss this question, which is very crucial and very important. And unfortunately, then we have testicular shrinkage because we administrate exogenous hormones, and then the body does not need to produce anymore either testosterone from the Leydig cells or sperm from the Sertoli cells. Therefore, the scrotum diminishes in size, the ejaculation volume as well, and the fertility. So many patients led to be azoospermic, unfortunately, but hopefully this is reversed in the long run by the use of HCG. Now, personally, I was using 10 years testosterone, but in the back of my mind, one day I wanted to have a family. So after 10 years of continuous use of testosterone, I was also, alongside using the HCG, I had a decent amount of 40 million spermatocytes. Okay, and I was able to conceive my wife at the age of 50. So you can still preserve your sperm with the HCG. All right. Now, there's another hypothesis that the use of HCG is capable of boosting the steroidogenesis, meaning the HCG improves the cascade of the steroid production from the pregnenolone to progesterone to DHEA. All right, and also it's a good libido enhancer because many people complain after starting initiating the TRT, Doc, I'm losing my sex drive, and the reason is because you kill your own production, and the HCG is capable of increasing the intratesticular testosterone, and of course greater scrotum size and ejaculation volume as well. Now, what about the DHEA? This is another player to the A13. You have a better sexual drive because as an androgen, even though that comes from the adrenals, it lowers the CTPG. We have improvement in cognitive function, in the immune system, it's prevention against Alzheimer's. Okay, now in women mostly because women do not have the dominance of testosterone, it can improve the body composition, oxidize the fat, and also of course it's a great stress management because it supports adrenal function, okay, and it fights adrenal fatigue. About the proviron, the mesterolone or the DHT, the use of DHT is beneficial for sex drive, cognitive function, and self-esteem. It crosses the CTPG and liberates more for testosterone. All right, and either could be on an oral form or it could be also as a cream. All right. Now the contradiction of DHT is the prostate cancer because literally it feeds the prostate if it's inflamed with cancer. Okay, and of course if you are prone to androgenic alopecia or male pattern baldness. Personally not, but there are many people that if you give them a little bit of proviron, they start losing thinning hair, okay? Now, what about the DHT blockers? Finasteride and dutasteride cannot block DHT itself. They can only block the reduction from testosterone to DHT, so it cuts off the equation. So if you want to preserve your hair, you need to use just testosterone. You cannot use proviron because proviron does not be blocked from the androgens. What about